Assalamu alaikum. Good morning, everyone. We'll talk about the top papers that has been published in the last year on the topic of HIV. I'm sure everyone have heard about the long-acting medications that has been circulating, and the so many studies looking at the top ones are very difficult, to be honest. But I chose not to present any of them, and I focused on controlling the complications and other risk factors mainly. So I have no disclosures. So we'll talk about these three studies mainly: the Slim Liver study, the Radiant TB trial, and the Reprieve trial, and with some honorable mentions. So starting with the Slim Liver study, I'll just talk about an introduction to this study, which is this cohort study, where they looked into the new onset diabetes in patients living with HIV and the correlation with non-alcoholic fatty liver disease and the entire spectrum, including NASH, liver cirrhosis, and hepatocellular carcinoma. So we know that the general population suffer from non-alcoholic fatty liver disease at 25 to 38%, and the rate is increasing. And there is a strong relation to obesity and other metabolic conditions. And these two, both of them increase the risk of diabetes and cardiovascular diseases. And in HIV, this is also exaggerated, but the exact onset is not well known. So as you can see in this trial, cohort study, they looked into whether the patient have baseline or they progressed to one of the non-alcoholic fatty liver disease spectrum, and whether it is associated with the onset of diabetes. And there was a very strong correlation. And there was also an association between the use of integrase inhibitors and TAF specifically and the new onset of diabetes and NAFLD. But what about the patients who are non-diabetics or not even did not reach diabetes yet? So in this trial, which was published last month, where they called it the Slim Liver study, they only published a small part of the trial. So they looked into a new term called MASLD, or metabolic dysfunction associated steatotic liver disease, which is defined as one or more major cardiovascular risk plus steatotic liver disease or fatty liver. So the combination is now called MASLD. And among patients living with HIV, the prevalence is higher, and the cardiovascular risk is substantially greater. Because steatotic liver disease is an independent risk factor for cardiovascular disease, reducing the intrahepatic triglyceride will improve, and the associated insulin resistance or inflammation will improve cardiovascular risk and will prevent the progression to further liver disease within the spectrum. So the objective of the study was to check whether semaglutide or GLP-1 receptor agonist does decrease the intrahepatic triglyceride, which is measured by a special type of MRI called MRI PDFF, or MRI protein density fat fraction. And the hypothesis is that semaglutide will decrease the intrahepatic triglyceride, which will eventually improve the cardiovascular parameters. The design was a pilot phase 2B single group open label trial. The population were patients living with HIV with central adiposity and insulin resistance or prediabetes, plus a 5% intrahepatic triglyceride measured by MRI, which labeled the patient as having a fatty liver. So the primary endpoint was 24 weeks change in the MRI PDF quantified intrahepatic triglyceride, but they did not have a target, any change, and they just want to look what will happen. The recruitment occurred over a year and a half. The inclusion criteria included adults, patients who are virally suppressed, no GLP-1 receptor agonist used within the past 24 weeks before recruitment, minimum waist circumference of 95 or 94 based on gender, and no diabetes diagnosis, but had one of the following, which is abnormal fasting glucose level, hemoglobin A1C that fits within the pre-diabetes parameters, and the HOMA-IR score, which depends on insulin level and glucose level of 3 and above. The parameters to ensure standardization of parameters. One of the authors read all the MRIs before and after. The insulin levels were done in one lab only, but the rest of the general labs were done in local labs. They had a cutoff for elevated ALT, which is 19 or 30, depending on gender, and they needed 50 participants to achieve 90% power, even with the fallout or exclusion of less than 25%. And the change of 5% in interhepatic triglyceride was significant to them. So they recruited 52, 49 only completed the protocol of the study. As you can see, the baseline characteristics included patients that falls within the 50s. Majority, the gender difference was equal in all groups. The median BMI was 35, so they were not very obese, but they're overweight. And all of them were virally suppressed. All types of medications were used, but majority were on integrase-based therapies. And there were 4 patients who had hepatitis C. So looking at the results, which is the most important thing in this study, the mean change in intrahepatic triglyceride was 4. The difference was 4.2%, which culminated into a 31% improvement in intrahepatic triglyceride. This occurred in 58% of the population, but what was surprising is 29% of the included patients had complete reversal of the fatty liver condition and muscle, completely resolved. Other parameters, there were no major differences in either the triglyceride level. There were some significant results in weight loss and other parameters, but when it looks muscle, only 29% completely reversed their condition. So there was significant improvement in anthropometric measurements, significant improvement in glucose regulation, significant improvement in triglyceride concentration, and all participants tolerated semaglutide without any side effects. Only few patients had grade 1 GI symptoms. The limitation of the study is that it was a small sample size, no control group, and they did not account for all factors that may influence this result. But as a pilot idea, the study was very appealing. In the published paper, it was a short review, so they did not publish all the data. But in the CROI meeting, they published some other, presented some other results, like the change in muscle volume and fat. And there was significant drop in muscle volume after use of semaglutide, but this drop did not affect the functionality of the muscle. All the tests showed no significant improvement. So next study is the RADIANT TB trial. So the idea behind this trial is that we know that dolutegravir is affected by rifampicin because it's a strong inducer, and it can decrease the trough level of dolutegravir by 85% in the serum. Yet tuberculosis is the leading cause of hospitalization in patients living with HIV in Africa. And in South Africa specifically, there are separate clinics that treat HIV and TB. And most of the patients, they don't adhere to the dolutegravir twice because either due to compliance issues, availability of medication, or cost. And in a phase 2 dose-ranging study in patients that were treatment naive, who were started on dolutegravir, they tried several doses compared to the standard one we use, which is 50 milligram. They tried 10 milligram, 25 milligram, and 50 milligram, and they all succeeded in achieving viral suppression, and they were comparable to the standard dose. Although it is not recommended to be done, but they tried it on actual patients, and it worked. And there was similar results in patients who tried the once daily versus the twice daily in combination with rifampicin, but it was a retrospective data. So in this trial, they tried to do it intentionally this time. So the objective was to determine whether virological outcome with standard dose dolutegravir-based ART therapy would be acceptable in patients living with HIV on rifampicin-based anti-TB treatment. So they conducted this phase 2B randomized double-blind and non-comparative placebo-controlled trial in a single clinic in South Africa. The primary outcome was virological suppression at 24 weeks. And in the secondary endpoints, they looked into suppression before that and after that. And they looked into changes in CD4 count, trough levels of dolutegravir, adherence of patients, adverse events, and changes in mini-mental screen and insomnia severity index, because most of the comparators were on efavirenz, so CNS symptoms was very important to them, and whether there was any emergence of integrase inhibitor resistance. Inclusion criteria were adults, seropositivity of HIV with viral load of more than 1,000, and CD4 of more than 200, but then later on they changed it to more than 100 to improve recruitment. They made sure all patients on rifampicin-based anti-TB therapy for at least less than 3 months, so it doesn't influence the outcome. Women of childbearing age were given also contraceptives to prevent pregnancy, so to decrease the dropout rate. They excluded pediatrics, patients with transaminitis, allergic patients, and any patient with psychiatric illness. Randomization was done using permuted blocks with a ratio of 1:1. The interventional arm received TDF, 3TC, DTG, which is a combination they called it TLD, in a fixed dose formulation, plus a supplemental matched placebo in the intervention arm, while the control arm received the same regimen plus a supplemental dolutegravir extra dose. The allocation concealment was done to the patients and investigators. Only the pharmacist had access to the information. While the rest were masked, and they wanted to achieve 70% suppression based on 2 previous trials done on efavirenz and rifampicin-based therapy. So they started with 140 patients screened, but they end up at 47 and 46 in each arm. The baseline characteristics included ages of median of 35 years old. Majority were male. Most of them had viral load in the 100,000, and the majority were pulmonary TB. Looking at the outcome, there was no differences in both arms. Those who received dolutegravir once and those who received dolutegravir twice had the same clinical outcome. As you can see, 6 out of the 9 patients who had failure of achieving viral suppression did not have viral suppression in the supplemental dolutegravir arm, and 5 out of 9 of the participants in the placebo arm had low-level viremia. So even those who did not achieve viral suppression had only low-level viremia, and no participant with virological failure developed integrase inhibitor resistance. In the adverse events, there were numerical differences, mainly in the placebo group, which is expected, as you can see, but none of them were statistically significant. So the limitation of the study is that it was not powered to make efficacy comparisons between arms. Only they wanted to show that there is no difference, and the finding may not be generalizable to people on other regimens other than dolutegravir first-line therapies, and people with lower CD4, like advanced diseases. Maybe this method should not be used with them. And they only enrolled participants who were ART naive or had an interruption in the first line and never moved to switch a different regimen. So the conclusion that the dolutegravir twice may be unnecessary in patients who have TB and HIV co-infection, but more evidence and cohort studies or phase 3 trials is needed to change the policies. So in the meantime, I think we should still go with the dolutegravir twice, since the difference is major in the trough level. So we'll move now to the honorable mentions. These are studies that only thought-provoking, but they're not major, to be honest, which is the doravirine-based dual therapy combined with islatravir. Islatravir, for those who doesn't know about it, it's considered a special type of NRTI, but it's called NRTTI, which is a nucleoside reverse transcriptase translocation inhibitor. This experimental drug is long-acting, oral, and it is pretty efficacious, but it's not been used in any commercial medication right now. And this is one of the studies that will even delay its use. So they tried it as a dual therapy, and they either they distributed patient into two arms, either to receive the dual therapy or to be started on integrase-based therapy and then to be switched at 24 weeks. And although they had comparable efficacy when it comes to viral suppression, there were significant drop in the lymphocyte count and CD4 count in the islatravir combination therapy arm, which is pretty concerning. And the other study was published on the same day on the Lancet, but I think it's the same cohort, but they included only patients who were on Biktarvy, since it is the most widely used medication, and the results were the same. Efficacy is good, but CD4, there was significant drop in CD4 and uh, lymphocyte level. So next we'll go to the Reprieve trial, which was presented by Dr. Bassem Rabdadi, but I'll just speak about a few things that he did not mention here, which is the use of pitavastatin to prevent cardiovascular disease and HIV. And this is, I think, hands down, is the most important trial that was done in the last year or published last year. So we know that ACVD risk among patients living with HIV is twice as high than the general population. And large cohort studies has shown that the increase in risk persists even after controlling the risk factors, just because they are living with HIV. And the calculators that we use to estimate the risk underestimate HIV and their treatment. And we know that statin has a major effect on cardiovascular risk factors. So hence this study, and they chosen pitavastatin specifically because it has very low drug-drug interactions with other antiretrovirals. So it was a prospective, double-blind, randomized, placebo-controlled, controlled multi-center phase 3 efficacy study among HIV patients currently on antiretroviral therapy. It was done all over the world, and they recruited more than 7,700 patients. All patients had HIV, ages between 40 and 75, with stable ART used, and they had low to moderate cardiovascular risk score based on the calculators that they used. They did not include the ones that have high risk factors. And the use of any statins within the past 90 days excluded these patients, and any patient with known atherosclerotic cardiovascular disease were excluded also. The primary endpoint were major adverse cardiovascular events, or what we call here MACE, and they looked into the composite death or MACE, LDL changes, and other safety events like the onset of diabetes, rhabdomyolysis, and these things. They used also permuted blocks for randomization, ratio 1:1, and they used pitavastatin calcium on low dose, which is 4 milligram, compared with an identical placebo. Both arms were given lifestyle modifications, but it was not followed up. So looking at the baseline characteristics, as you can see, the mean ages were in the 50s. Majority were male, and the cardiovascular risk score was at 4.5 in the majority of the cases. Most of the patients were late presenters initially, but they were started on they were recruited in this study when the CD4 was above 500 in the majority, and the majority had viral suppression. Some of them had low-level viremia, but the majority were virally suppressed. And as Dr. Bassem Radadi explained, they did meet the primary endpoint of this study regarding the MACE. But when you look at the details of it, if you look at the details of MACE or the major adverse events, the only significant one was MI. But when you look at peripheral vascular disease, stroke, and these things, it was not clinically significant. When you look at the other subgroup analysis, there were major differences in a lot of categories, including the majority of those who benefited are those who have risk, ACVD risk between 5 and 10, which is the moderate group, not the low group. The majority were above 60. Those who were younger did not benefit much. And the majority were male. They either were never smoked or former smokers. The current smoker, even with pitavastatin, it did not change anything. And majority of those who benefited did not have hypertension also. So just to show that smoking and hypertension are way more important than statin use. LDL were less than 130 in those who benefited the most. And also CD4 was above 500 in the majority of those who benefited. Our duration also, which is important, the majority of those who benefited were the ones who had HIV for more than 10 years and were on treatment for the entirety of this period. The newly started or the ones that has less than 10-year experience in ART did not benefit much from the use of statin. And when you look at the adverse events, the pitavastatin performed worse in the new onset of diabetes and in myalgia. But in rhabdomyolysis and other adverse events, it was comparable between both groups. So the limitation of the study is that the trial was done only in pitavastatin, but probably other statins would have the same effect and maybe even better. Other modalities to drop LDL were not studied in, were not accounted for in this study. And the conclusion is that in patients living with HIV who have low to moderate risk factors, there is a pitavastatin use showed significant improvement in the risk of MACE or the major adverse cardiovascular events within the first 5 years of use of this medication. And the impact of this study is what makes it so important. In the DHHS guideline in February, they changed their guideline and they introduced the new recommendations for statin use in low to moderate setting between 40 and 75 years of age. And they included 3 different statins as recommended. First is pitavastatin, atorvastatin, and rosuvastatin at the low to intermediate intensity. While British guideline went so far to even recommend starting statins in any patient who living with HIV that is above 40, regardless of LDL level or cardiovascular risk. And what came after that is that even some people are suggesting now HIV pharmaceutical companies to start producing antiretroviral plus statin co-formulation in a single tablet just to decrease the pill burden on patients, since it is going to be used in almost all patients in the future. And thank you for this.